Good morning. This is a special day for me. I'm at the pleasure of telling you a little bit about Huldrych Kammer and the person for which this lecture is meant to honor. Dr. Kammer came from a large family in the upper Midwest, served in World War II with distinction, and then following discharge from the Army, went to the Cleveland Clinic to get a fellowship training in endocrinology. Through contacts with friends and family and so forth, he chose Portland, Oregon as the place that he wanted to make his residence. He became quickly the leader of endocrinology in the greater Oregon area as well as Portland. We used to call people like Huldrych a triple threat. He was a practitioner who was just loved by all of his patients and colleagues. He had a practice at downtown Portland, and he constantly had medical students and residents, and myself included, spending time in his office as this parade of endocrine patients walked by his exam room. We quickly saw patients with huge goiters, which were quite obvious, 7-foot plus patients with acromegaly, et cetera, et cetera. All this time, he was also doing clinical research at the medical school and helping to build the division of endocrinology at the medical school. He was on the crest of the wave when it came to clinical research. His thirst for knowledge was insatiable. He constantly wanted to keep himself and the rest of us on the cusp of endocrinology. He won every teaching award I think that we had to offer, including the highest award that's provided by the Oregon chapter of the American College of Physicians, the Laureate Award. So we're very pleased today to continue the tradition. He saw to it before he passed on that the Kammer name would continue to be associated with endocrinology and the very latest in the field. And so we're going to have the pleasure of hearing about that now. But we really want to remember Dr. Kammer for all of the great things he did for academic endocrinology in the Portland and the Oregon area. Thank you for letting me say a few words about Dr. Kammer.
Dr. Gilbert, thank you so much for your heartfelt words. What a tribute to hear from a friend and colleague who knew Dr. Kammer so well, both professionally and personally. And it is an absolute delight to carry on this tradition and introduce the 2025 Huldrych Kammer Memorial Lectureship. We will start with just a few reminders and logistics and then introduction of today's speaker. Please be sure to join us next week as well. We have the good fortune of another endowed lectureship, the Edelson, and we will be hearing the talk Healing Mindfully by Dr. Ni-Chang Lang. She's an integrative and pulmonary medicine doctor from Scripps in San Diego. So delighted to see so many colleagues here in the audience. We are here live at Providence St. Vincent Southern Auditorium, and welcome to all of you who are also joining us virtually. You can earn CME credit for being here in the room, for watching live virtual, or by watching a recording of the event. Each week's Grand Rounds invite will let you know where we're meeting and also has the link to the video recording. For anyone who is able, this presentation will also occur live in the auditorium at Providence Portland Medical Center today at noon. As acknowledged by Dr. Gilbert, we are so grateful for the tireless dedication to clinical excellence and scholarship and education that Dr. Kammer left for countless medical students, residents, and his fellow colleagues. So welcome to all the learners here in the room. And it's an honor to introduce today's speaker. We are joined by Dr. Mandy Clark, Professor Emerita at Oregon Health and Science University, and a senior affiliate investigator at the Kaiser Permanente Center for Health Research. She is board certified in obstetrics and gynecology, as well as urogynecology and reconstructive pelvic surgery. She is also a certified practitioner of the Menopause Society. Dr. Clark had held a full-time faculty appointment at OHSU for 23 years, followed by 10 years at Kaiser Permanente Northwest. In addition to clinical practice, she has been academically active in both teaching and research. She has more than 40 years of experience teaching students, residents, fellows, and has broad experience in curriculum development and assessment. She's a member of the editorial board of Menopause and conducts peer review for several journals. Speaking of the triple threat, thank you so much, Dr. Clark, for joining us today.
Thank you for your very kind introduction. I didn't know Dr. Kammer, but I've heard stories about what a wonderful teacher he was, and I'm quite honored to be giving this lecture in his name. So here are my disclosures. And our objectives today are to define perimenopause and describe the physiology, and to discuss treatment options for symptoms, for contraception and abnormal menstrual bleeding that happen during the perimenopausal period, and to talk about what happens to bone during this transition. Start off with definitions. So menopause is defined by the cessation of ovarian function. We don't have a great test to know exactly when that happens. So we have arbitrarily defined menopause as the final menstrual period after 1 year of amenorrhea. So because of this, it's always a diagnosis in retrospect, which is very helpful for research, but is not helpful at all for clinical medicine. The median age is 51 to 52 years, and our diagnosis based on amenorrhea is not helpful in a number of women, those who have amenorrhea already, those who've had a hysterectomy, have an IUD in place, or continuous hormonal contraception who don't have menses to tell us when that final menstrual period has happened. We also can induce menopause by bilateral oophorectomy and with radiation and chemotherapy. Couple of other definitions. When menopause happens between the ages of 40 and 45, we call it early menopause. After 45, it's considered within the normal ages of menopause. And then premature ovarian insufficiency is when ovarian function ceases before age 40, which is often autoimmune or genetic, but again, can very often be idiopathic. So we're not going to talk about those today, but just to have those definitions out of the way. There's very confusing terminology around perimenopause and the menopause transition, and you'll probably see me use the terms slightly incorrectly as I speak today, just because everyone does that. So the stages of reproductive aging were clearly defined by the straw criteria about 10, 15 years ago. And in this, they defined the menopause transition and perimenopause as different entities. So both of them begin when we have the first onset of menstrual irregularities. So the cycle varies more than 7 days in length, or one menstrual period is missed within the past 3 months. The menopause transition defines the period of time between that beginning and the actual final menstrual period. Perimenopause goes to 1 year beyond the final menstrual period, which also coincides with early postmenopause. So it's confusing, but it is what it is, and I just want you to know about it when you read journal articles, that being clear on these types of terminology is what they're talking about, not what we globally talk about. The menopause transition is the whole thing. Perimenopause is the whole experience. Clinically, that's how we think of it more, but there are specific definitions. So it's going to do a quick review of the menstrual cycle just to remind you of a few things that we'll talk about what changes in perimenopause. So the first half of the menstrual cycle is the follicular phase. During this time, FSH stimulates follicle development so that we see a rise in estrogen and the uterine lining grows in thickness. I don't have an arrow for it, but you notice in the second half, there's also a second bump in estrogen in the mid-luteal phase. At mid-cycle, there's an LH surge, which leads to ovulation. In the second half of the cycle, the follicle becomes the corpus luteum and produces progesterone. The uterine lining differentiates, which prepares it for pregnancy. We call this the secretory phase. And when pregnancy doesn't happen, estrogen and progesterone are withdrawn, and we have menses and shedding of the lining. So menopause results from follicular depletion, so follicles can no longer do this. In the menopause transition and in perimenopause, we differentiate an early phase and a late phase leading up to the final menstrual period. So in the early phase, there are fewer follicles than in premenopause. There's less inhibin B and anti-Müllerian hormone produced by the ovaries, which leads to a slight increase in FSH. With the higher FSH, there's faster growth of the remaining follicles, which leads to a shorter follicular phase. And then there's something that happens called a luteal out-of-phase loop, which I'll show you in a next slide, that leads to a lot of the hormonal changes that happen during this time. Estrogen levels are quite variable during this time and sometimes quite elevated compared to premenopause. So the symptoms in the early phase tend to be more heavier and frequent bleeding and more signs of excess estrogen. So breast tenderness, irritability, but some vasomotor symptoms when estrogen levels fall rapidly and the beginning of sleep disruption. The median age of this is age 47. For all of these endpoints, the time between onset and the final menstrual period is longer before the final menstrual period than after. So whereas before menopause goes from 55 to 52, after menopause is 52 to 55. So those ranges are much shorter in terms of the phases that happen. So this is what a luteal out-of-phase loop looks like. So here you see the rise in estradiol. This graph doesn't show progesterone, so you have to remember where it happens. So in a cycle, estradiol rises as expected. Ovulation happens at mid-cycle. But because FSH is elevated, another set of follicles is recruited before this cycle is completed. So normally that wouldn't happen until after menses. And so estrogen levels go even higher. Progesterone still happens and is withdrawn, so you get menses, but menses are happening at the same time as the next ovulation. So this next cycle may be shorter and it may be heavier or lighter because everything is out of phase. This happens in one of 4 cycles in early menopause, and later up to a third of women experience these. So they're quite common. The late phase of the menopause transition, or perimenopause, is defined as when amenorrhea lasts for up to 60 days. So now at this phase, there's fewer follicles, many fewer follicles, less estrogen production, less regular ovulation. We see lower levels of estrogen and progesterone, and symptoms are more like what we expect after menopause. So more vasomotor symptoms, more sleep disruption, mood changes, genitourinary symptoms start at this time, and bleeding tends to be lighter and less frequent. I'm not going to talk about it, but in midlife, that's when gynecologists see fibroids, adenomyosis, polyps, and a lot of things that cause excess bleeding that aren't part of the menopause transition, but are part of our clinical assessment. So what we know about perimenopause has been greatly enhanced by the study of women's health across the nation, which is often referred to as the SWAN study. So this was a study that began over 20 years ago at 7 U.S. centers. It was a multi-center longitudinal observational study that went out of its way to have a good mix of various races and ethnicities. And in this study, they observed what women did over the years. They and their doctors were free to make their own decisions about care, but they were observed, and they were enrolled in premenopause at between the ages of 42 and 52, or in early perimenopause when there had been at least a skipped period. And in this one study, they did various assessments annually. This is a chart showing what estradiol, FSH, and NTX do as women progress through menopause. And this line in the middle shows the timing of the final menstrual period. So this is how many of the SWAN diagrams are presented, with the final menstrual period in the middle and years before on the left and years after on the right. So we see that estradiol begins to decline 2 years before the final period and stabilizes 2 years later. FSH behaves inversely and so starts to rise 2 years before and stabilizes 2 years after. And NTX, which is a marker of bone resorption, increases as estrogen declines and FSH rises. But this is what happens in the aggregate when you average the results from 2,000 women. It makes it look like we could just measure those values and know exactly where women are in their transition. But alas, this is not true. And this is what a chart of daily levels of estrogen and progesterone look like. This is over 180 days in a perimenopausal woman. The open squares are estrogen, the filled squares are progesterone. And we see that it's quite variable, with big peaks at some points and low troughs at other times. If we superimpose what we would expect, this is from the menstrual cycle before, we would expect sort of sine waves of hormonal changes as women go through those 6 months. But we see that there's nothing like this. So how do we diagnose perimenopause? It's a clinical diagnosis in a woman who's over age 45 and has the onset of menstrual irregularity and or symptoms. That essentially is our diagnosis of perimenopause beginning. Laboratory testing is often not helpful due to that variability that I just showed you. So we can certainly measure the levels and it tells us what's happening today, but it doesn't tell us what's going to happen tomorrow or when menopause is actually going to happen. We should consider other causes of anovulation, hypothyroidism, polycystic ovarian syndrome, prolactinoma. And in women who are less than age 40, who present with menopausal symptoms, irregularity, that's a time where we really want to think about the diagnosis of primary ovarian insufficiency, which is characterized by high FSH and low estradiol. For this, we do measure blood levels at 2 different time points at least because of the variability even at this time. And to be aware that hormonal contraceptives suppress ovulation and they make FSH and estradiol levels uninterpretable. So when you're checking for that, they can't be on exogenous hormones. So from SWAN, we learned a lot about symptoms women experience as they go through menopause, with hot flashes and night sweats being the cardinal symptom. I was taught that menopause hot flashes lasted for 1 to 2 years and were generally mild. And SWAN showed us that that is far from the truth, that VMS affect 80% of women. About half of these report moderate to severe bother. The median duration is 7.4 years, and it varies according to race and ethnicity. Hot flashes persist for 4.5 years after the final menstrual period, which means that they have the onset at least 3 years before the final menstrual period and 4 years before we diagnose their final menstrual period. So we have to think about symptoms well before menopause happens. And hot flashes are related to both low estrogen levels and falling estrogen levels. We've also learned from SWAN that hot flashes may be a marker for cardiovascular risk. In the WHI, it was noted that incident coronary heart disease was higher in older women who had VMS at baseline. And in SWAN, this was looked at more precisely, and vasomotor symptoms were associated with changes in vascular responsiveness. So this flow-mediated dilation test is one in which the brachial artery was occluded with a blood pressure cuff for 4 minutes. And after release, the dilation of the brachial artery was measured by ultrasound. Women with VMS aren't able to dilate their artery as much as women who don't have VMS. So we know there's an effect on vascularity. And also in SWAN, women with VMS had increased cardiac and aortic calcification. We'll talk a little bit more about this in terms of treatment later. So symptom management at perimenopause involves all the typical menopause symptoms listed here, but we also need to think about abnormal vaginal bleeding and fertility. So fertility is much lower during perimenopause, but it's not yet lost. And if you look at we don't have a test or a switch that says, okay, you can't get pregnant now. And so just going by FMP, it takes until age 55 for 95% of women to have reached their FMP. So we need to think about fertility for a much longer period of time than our women want to think. So that leads me to sort of 3 major groups to think about in terms of managing perimenopausal symptoms. The first one on the left is supplemental estrogen plus a progestin IUD. So the IUD provides contraception. It suppresses menstruation. Many women have amenorrhea, and so no menses at all. This approach maintains their bone mineral density and is an easy transition into menopause hormone therapy. Essentially, you're giving it, but using the IUD to provide the progestin. It doesn't suppress ovarian function. So if a woman's having really high estrogen levels and is symptomatic because of that, she may do better on continuous oral contraceptives. These suppress ovarian production, and so women have stable hormone levels provided by the birth control pills. It's important with this to do a continuous regimen where you don't interrupt it in order to have them have a menstrual cycle, because they'll have symptoms during that week off of the hormone medications. So it also suppresses menstruation, maintains BMD. We worry about the duration of use in the older years, mostly because of the coagulopathy, although in healthy women, it's still a quite low risk, but there's also a lot more medical contraindications to contraception. We can start menopause hormone therapy to address symptoms. That certainly will help with hot flashes. So in doing this, we typically are aiming to sort of fill in the troughs of estradiol or to give supplemental estrogen for women who have waning estrogen. This maintains BMD, but it's not contraceptive and it doesn't suppress menstruation. So women who will continue to have unpredictable bleeding, if we give them progesterone in a cyclic fashion, we can induce menses, but we don't know when their ovaries are going to do the same thing. We can also give continuous progesterone. Again, it doesn't interrupt cycles, and so whatever is going on in terms of irregularity, we don't change that. So women who are very unhappy with unpredictable bleeding don't do well with this option. I'm going to briefly talk about abnormal vaginal bleeding. This could be an entire lecture or 2 or 3, but just things that I think about in relation to hormone therapy. Abnormal vaginal bleeding is the sentinel symptom of endometrial cancer. So we have to take it seriously. But most abnormal vaginal bleeding, particularly perimenopause, is benign, which can lead to a lot of negative testing, which is costly and quite uncomfortable. Progesterone is what protects the endometrium, and the only way we get that naturally is when the ovaries are producing it after ovulation. So when an ovulation happens, we go through a period of unopposed estrogen stimulation of the endometrium, which can increase risk. We want to think about risk factors that women come to menopause with. So age, they're still at a younger age, but prolonged anovulation from PCOS for years before menopause, being obese, having diabetes, all raise the risk of endometrial cancer and make us worry more and need to test more. It's important to know that endometrial protection comes from the progesterone-induced differentiation, not withdrawal bleeding. So giving 7 days of estrogen to cause a period isn't protective. We need 12 to 14 days at least if we're going to do sequential, and we do even better with protection with continuous progestin. So managing bleeding reduces the risk of cancer, reduces the net need for testing, and often makes women a lot more comfortable because they don't have to worry about unpredictable bleeding. So it's an important aspect of perimenopausal care that's different from menopause care. And in terms of what I consider abnormal, just the quick and dirty is cycles shorter than 21 days are often not ovulatory bleeding. Any intermenstrual or irregular bleeding is worrisome. But there's not a quick answer, and there's not a guideline, and there's not an algorithm. We just have to kind of think through all the clinical parameters and make our best guess. Bone health at perimenopause, we have an opportunity to prevention that we haven't adopted as fully as we could. So with SWAN, we learned a lot about what actually happens to bone as women go through the menopause transition. In SWAN, there were 860 women who transitioned through menopause without any hormone therapy or other bone active medications, and who had annual DEXA testing for BMD. Prior to the WHI, estrogen was extensively studied for osteoporosis prevention, and we pretty much figured out how to do it. But then the WHI was published, and despite the fact that the WHI demonstrated fracture protection, we abandoned all sort of thought of use of hormone therapy and how it affects bones. So I'm going to talk to you more about that. So here's what happened put to bone mineral density as those 890 women went through menopause. So the chart on your left is lumbar spine, BMD, and on your right, femoral neck. That line in the middle is the final menstrual period. And then remember, the diagnosis of menopause officially happens a year after that, so that you can see that as women, by the time we have diagnosed their menopause or their diagnosed menopause, they have already lost half of the bone mineral density that they're going to lose across the menopause transition in the spine and a third in the hip. For years, I knew that this was around a 10% loss. And as a clinician, that didn't mean much to me. I thought, 10%, still 90% left. That's an A-, that's good, no big deal. But Dr. McClung one time mentioned to me, well, that's a full T-score. And I'm kind of like, full T-score. So if you start at minus 1.5, at the end of menopause, you're going to have osteoporosis. And it turns out, as I will show you, that that's essentially true. So preventing this big loss that happens at menopause is very potentially useful for bone health in later life. So this is a plot of bone mineral density starting at midlife and extending into aging. So in the 40s, bone mineral density is pretty stable. At menopause, we see that steep decline that comes directly from SWAN that I showed you before. And after that, there's an age-related loss of bone that's demonstrated in the NHANES database of about 0.5% per year. So for a woman who enters menopause with a normal BMD around 0, following this curve, she would develop bone density-related osteoporosis in her early 80s. However, if she starts out at lower than that with low bone mass, say this is about minus 1.3 or 5, then she's going to pass that threshold for osteoporosis at a much younger age, in her early 60s. And we know that there's actually a significant number of women who have a low bone mass. So 40%, we don't have these numbers for perimenopause, but around those ages, there's a significant number of women for whom this is important. And if we wait until they're age 65, we can't prevent osteoporosis anymore for a number of women. In SWAN, they also looked at trabecular bone score, which is a measure of the trabecular architecture. Again, you see that typical SWAN slide on the left with the line representing the final menstrual period. On the right is the lumbar spine bone density that I showed you before, just for comparison. And TBS, trabecular bone score, starts to decline about a year and a half before the final menstrual period. So we see BMD changes a little before the trabecular changes. And then and there's our diagnosis of menopause a year out. And then I've just superimposed the hormone charts that I showed you before that show how TBS and spine density track with the hormonal changes. So one of the things that was really helpful in my education about bone is kind of understanding what bone remodeling looks like. The bone people talk about it a lot because they know what it looks like, but the rest of us, at least the gynecologists, don't particularly appreciate what that looks like. So I found these videos by Dr. Susan Ott, a nephrologist at the University of Washington, who used actual slides to make videos to show the process. So here I'm going to show you a video of what bone remodeling looks like in adults in a premenopausal woman. So every year, 10% of bone is turned over. So resorption cavities are formed and then filled back in order to turn over bone. But the processes are matched, and so the bone mineral density and architecture is preserved. After menopause, though, the resorption is accelerated and formation can't keep up. And so we see deeper resorption cavities, and they don't fill in fully, and they lead to thinning of the trabeculae and breaks that occur. And these are changes that we can't fix. When we add back estrogen or give a bisphosphonate, we fill in the resorption cavities that are still left, but we don't rebuild bone, reconnect the architecture, thicken the trabeculae. The osteoanabolic drugs do that somewhat, but none of the treatments we have now can restore this back to the premenopausal state. So back to the studies that we did in the 90s, we weren't able to study, or studies haven't been performed in perimenopausal women, just because it's so hard to know where you are in the process of perimenopause. All the studies we have are for women in early postmenopause. So this was a prevention trial comparing hormone therapy to prevention dose of alendronate over 4 years. And you see the curve for hormone therapy is actually a little bit higher than prevention dose alendronate, showing a very similar profile to alendronate as an anti-resorptive drug. So you get meaningful increases in BMD with both agents. When you look at what happens, though, at discontinuation, it's very different. Alendronate has a slow off effect, so BMD doesn't drop precipitously, but after hormone therapy is stopped, we get even a faster drop than we saw in natural menopause. So at 1 year, back to baseline, and by 2 years, we're back below baseline. So MHT briefly improves bone health, but doesn't beyond when it's stopped. Can we do something about this? Yes, there was a trial again back then that looked at giving women alendronate as they discontinued hormone therapy, and that's what's shown in this graph over 1 year. So the alendronate group gained a little bit more bone, where the placebo group had that steep drop as we saw before. So when we give hormone therapy to women for a brief period around the menopause transition, as is shown here, we do protect their bone from fracture and maintain BMD. But as soon as we stop it, they go through that rapid loss, and they're back on track to have never had taken hormone therapy. So a lot of women are like, there's a lot of stuff on social media about estrogen and protecting bone health. And yes, it does, but it doesn't do anything for the long term. And at midlife, fracture risk is low to start with. So we do prevent some fractures, but that's not the worrisome time. So we'll talk about treatment versus prevention. So this is the curve of the same woman who enters menopause with low bone mass. She isn't treated at the time. She doesn't have a DEXA until age 65, and at that time she has a T-score of minus 2.7. If we treat her with bisphosphonate, we'll get a 6% rise over 3 to 5 years and bring her up to a T-score of minus 2.4. If we do our best treatment with romosozumab, which is the osteoanabolic, we can do better and bring her up to minus 2.2. But this is not, neither of these are the ideal target for fracture prevention. We'd like a BMD of 2 or even a minus 2 or minus 1.5. But part of the reason that treat to target hasn't become a thing in osteoporosis is none of our drugs can get us to those targets. However, with prevention, if a woman stayed on estrogen just arbitrarily, we put her to age 65, and then followed it with bisphosphonate therapy, we could, in theory, keep her BMD at the level that she had in midlife and give her fracture protection for the remainder of her life. So how would we actually do that? That would be, and I was going to say, it's overall easier, more effective, and less expensive to prevent osteoporosis than it is to treat it. So how would we do that? Here's a couple of ideas for how a lifetime plan for bone health might look. After stopping estrogen, we could give alendronate if we're just aiming to maintain and not to further raise BMD for 2 years, followed by a 3-year holiday, and do that every few years, and to a point where we could give intravenous alendronate and go for a longer period or stop treating. If a woman needed risk-reducing therapy for breast cancer, we could put a course of raloxifene into that lifetime plan. Or if she wanted, we could do intermittent zolendronate for maintenance every 5 years. And the total cost of these medications today for a lifetime of treatment would be around $4,000, which is way cheaper than our osteoanabolic drugs would cost. So the data to support this approach would be this study showing what happens when you give alendronate for 2 years and then stop it for 3, that you maintain BMD. And then in a very new study in the New England Journal earlier this year, this was a study that looked at giving zolendronate for prevention in early postmenopausal women. So these are women who'd gone through menopause, had low bone mass, not osteoporosis. They were given a dose of zolendronate 5 years apart and followed for 10 years. And they both maintained their BMD and had fracture protection, even though they are at low fracture risk to start with. So there's evidence to support this approach. So overall, treatment at perimenopause differs from menopausal treatment in that estrogen is not yet absent. So we want to stabilize levels, not replace it at this stage. Progesterone is waning, and we may want to supplement it to help manage bleeding and keep down the risk of endometrial hyperplasia. We may want to suppress ovarian production to alleviate the big swings. We can supplement the troughs, and to preserve skeletal health, we want to think about DEXA testing either prior to menopause in midlife before the decline has happened, or if we treat them with estrogen, to test before we stop to help us decide if we want to do something more to protect bone. So the commonly used hormone therapy regimens, so I'm not going to talk about birth control pills. They're all essentially the same in terms of managing symptoms, other than, again, continuous, not interrupted. So these are the common doses of estrogen that we use today. When patients will tolerate it and can afford it, the transdermal route is preferred because there's no increase in coagulopathy or gallbladder disease with this, but there are a number of women who don't want this approach. And so for young, healthy women, the coagulopathy that comes with oral estradiol is quite small. In addition to the patch, there are estradiol gels, sprays, and one of those is now generic, which helps greatly with the cost. We talked about the IUD, and I put it on here just as part of the list for overall hormone therapy is Duovi, which is a combination of estrogen and a SERM, which blocks estrogen action in the endometrium and provides the endometrial protection. I don't know of much experience with using this in perimenopause. Its great benefits are that for women who have progesterone side effects, it's a great option after menopause. And there's less of the sort of pesky bleeding that you get with hormone therapy. There's a theoretic benefit in terms of breast in that it doesn't cause increased breast density like progesterone does. So I mention that just so you know about it for hormone therapy, but I don't know of anyone who has experience using it in perimenopause. On the social media, there's a lot of interest in bioidentical hormones. Medically, we mean estradiol, the same thing that the ovaries make. But a lot of the proponents of it say that it has to be compounded and dialed in to meet exact hormonal needs of women. And that's really not useful. There's a lot of marketing around this. And so I don't recommend compounded preparations. Probably the biggest advantage of them is that they don't come with a box warning. So women don't get any information. As to dose, what dose do you use? There's very clear dose response curve in terms of bone related to estradiol dosing, somewhat with hormone therapy. With hormone therapy for VMS, we can start with a low dose, see if it works, a month later, bump it up if we need to. But for bone, we can't do that. We have to look at it over big periods of time. And there's a dose response curve. And the dose equivalencies that we typically say of 0.625 of Perimen, 1 milligram of estradiol, a 0.05 patch come from these bone dose response curves. If you have a woman who comes into menopause with low bone mass, then I would start her on at least this equivalent, a 0.05 patch or milligram of estradiol, because you know that you want to optimize her bone response. For women who you don't know that, certainly for treating symptoms, you can start low and bump up, but we don't know what we're doing in terms of bone health when we do that. There's a fair bit on social media about estradiol levels and targeting those. None of the dose ranging studies report serum levels. So many of us are kind of wondering where that information comes from. As I said, we know that there's fracture protection at the level of 0.625 of the conjugated estrogen used in the WHI, and that's where we get those equivalent doses. You can find estradiol levels in the prescribing information for all of the products. And so here I've listed them so that you sort of know what to expect. But I don't really see a reason for checking them because the route of administration affects estrogen action. If you give it orally, there's increased sex hormone binding globulin, so the active amount of estrogen is going to be less. You also get more conversion to estrone, a weak estrogen that's circulating. With transdermal, the estradiol levels are 1-to-1. And so the one reason I might check it is if I'm worried that the patch for some reason is not being fully absorbed. You can check a level and see if it matches what the prescribing information says you should be getting. But for the most part, I don't use estradiol levels. As to hormone safety, I'm not going to go into the details of the WHI, but I will show you this chart of the WHI analysis for the 50 to 59-year-old cohort, which is closest to our perimenopausal age group. On the top, you see the conjugated estrogen alone. On the bottom, estrogen plus the medroxyprogesterone. The red bars indicate risks and the blue bars indicate benefits of the therapy. So at a glance, you can tell that there's more risk with the progesterone than there is with the estrogen alone. The red dotted line that you see across there is the 1 in 10,000 risk. And that's what the FDA considers a rare side effect. So when you're looking at prevention, which is what the WHI was about, you don't want to accept risks much at all. But when you're looking at a medication that gives obvious benefit, then the risk profile is viewed in a different perspective. And so it's important to recognize that all the risks that the WHI identified are in the rare category for this age group of women. We now know that we can mitigate these risks in terms of coagulopathy, stroke, and coronary heart disease by transdermal therapy and early initiation around the time of menopause. And that means that breast cancer with the progestin is the one risk that we need to think most about, and certainly our patients think most about. Before I talk about breast, I wanted to talk about this study that was just published a couple of weeks ago. I said that hormone therapy or having vasomotor symptoms is a risk factor for cardiac disease. And we didn't know whether or not treating was safe in that group because we might be worsening it or better. And that they reanalyzed the WHI, looking at women who had vasomotor symptoms at baseline, so the group that we would think about treating. And we see the same pattern that we see across the WHI, that for women in their 50s, treating reduced the risk of coronary disease. In the 60s was even, and in the 70s, we saw an increase in risk. So this is the best data that we have that supports that treatment of women who have significant hot flashes certainly doesn't harm their ongoing cardiovascular risk. So now to breast cancer. This is the hardest thing to talk about in terms of hormone therapy. The only randomized controlled trial data of sufficient size that we have is the Women's Health Initiative, which was conjugated estrogen and medroxyprogesterone. And we don't use those preparations anymore today. So one of the criticisms is that it used approaches that we don't use currently. But this is the only data that we have, and it showed a 1.28 increase risk in the breast cancer when progestin was present, and a 21% protection for estrogen alone. And so everything else that we know and think about this comes from speculation about what those numbers mean, but those are the only 2 points of hard evidence that exist around breast cancer. A simple answer would be to say progesterone causes breast cancer and estrogen's protective. There's also thoughts that the conjugated estrogen has SERM-like effects that are protective that you might not get with estradiol, that there's a benefit to going without estrogen for several years and then adding it back. There's a whole lot of speculation about what this means. Observational studies, which I show here, for estrogen and progesterone, give numbers that are similar to what the WHI showed. So supporting the idea that there isn't a progesterone effect. Studies of estrogen alone, though over many years, show an increased risk in observational studies. But I'll point out that there's bias in observational studies that we need to think about. And in particular around hormone therapy, there's the healthy woman effect that favors the benefits of MHT. But for breast cancer, we also know that more mammograms, women on hormone therapy tend to get their mammograms. The more we do, the more we diagnose breast cancer, knowing that many of them are subclinical that would never, ever present and be a clinical problem. So we're really left with the dilemma of not being able to know exactly as we would like to about breast cancer. I'm going to talk about now the magnitude of that. When you compare the magnitude of the risk for hormone therapy, it's comparable to other modifiable risk factors, comparable to that for alcohol intake of 1 to 2 glasses a day, of being obese and being sedentary. So we don't typically take a glass of wine and go, oh my God, I'm going to get breast cancer, like so many women do when they take their estrogen. And then just one more comparison in terms of magnitude. For the observational studies that look at endometrial cancer with unopposed estrogen, that risk is tenfold. For smoking and lung cancer, it's 26-fold. So the risk associated with smoking and cancer is 100 times the risk of the association of breast cancer and hormone therapy. But it's a very difficult concept to convey to patients because they and all of us know women in midlife with breast cancer. It's very common. So the risk is high. The attributable risk related to hormone therapy is actually small overall. I'll mention briefly non-hormone therapies for women who can't take estrogen. There are benefits for the mood changes as well as hot flashes related to our SSRI and SNRI antidepressants. Gabapentin has some effectiveness for vasomotor symptoms and helps with sleep. Fezolinetant, the newest medication that we have, and its cousin elinzanetant, I think is how we are supposed to say it, is expected to be approved within the month, are new agents that specifically target a mechanism for hot flashes in the brain, which help with both VMS and sleep. Non-medical interventions for vasomotor symptoms are cognitive behavioral therapy and clinical hypnosis, but it's very hard to find people who provide that for menopause. Supplements, yoga, acupuncture, mindfulness have all been tested in randomized controlled trials, and in those trials do not show a benefit above placebo. So if patients are on these and it's working and they're happy, I don't discourage it. But when they come to me and are paying money or, want my expertise, I don't recommend those things. So overall, perimenopause is about managing uncertainty. We start treatment way before the final menstrual period. We need to recognize that bone loss starts earlier, way earlier than the final menstrual period, and that menopause is essentially a discontinuation event of an osteoporosis medication. Patients come with these common questions of when will my menopause happen? When will I feel like myself again? And it's very frustrating for us and our patients to be unable to give precise answers. We don't know as much about perimenopause as we like, but we want to educate and inform and help set expectations so that they know that menopause is not a moment when everything goes back to normal, but that it's a long process that we need to help them through. You want to guide them to good sources of information, and I've put those here: the Menopause Society, ACOG, and a new group, a nonprofit called Her Medicine, that tries to fill the gap in women's medical education for both clinicians and for women. Resources that are open access are position statements from the Menopause Society, created by multidisciplinary clinicians to give you the data and the information that I've not had time to present today. The Oregon Echo Network, we provide a 12-week course about menopause and primary care, which is free, provides CME, and is open to all. That will happen again next April for more detail. And we have a curriculum for resident education that includes a podcast, a PowerPoint, handouts that were tested here in this very internal medicine residency a few years ago as helpful guides. So I will conclude there. Thank you for your attention. I look forward to your questions.
Dr. Clark, thank you so much for your depth of expertise and real clarity in teaching. I've already learned a lot. Questions here in the room?
Dr. Gilbert.
Dr. Gilbert, I'll have you speak into the microphone.
I can't help but wonder what Darwin would say. You did a beautiful job reviewing the natural history, etc., and focusing on bone, and then at the end you got a little bit into coronary artery disease and so forth. But if bone remodeling is part of the natural part of the end of our lives, if we're a female, would Darwin say that's bad? I mean, maybe there's something we're missing it's a confounding factor that it would take thousands of years to detect rather than a 5 or 10-year follow-up study.
Well, we certainly don't have clinical trials to demonstrate the benefit of prevention, but we go back to the time before medicine in the around 1900, the natural lifespan was often 54 years, so women didn't live long beyond menopause. So as we've extended the lifespan, I think we have to think about how to optimize that. And Darwin might not agree with cataract replacements and joint replacements and all of those things that we do. So why not?
Yes, very nice talk. One of the concerns we have, or at least I have, in giving hormone replacement therapy is those women who are destined to develop estrogen receptor positive breast cancer itself. And there's some recent studies showing actually that it's the progesterone that induces in those neoplastic tissues increases in the estrogen receptor. Any insight?
Totally agree with you. If we could make breast cancer go away, then we'd all feel much more comfortable about hormone therapy. Using an IUD certainly provides a lower level of systemic progesterone, but the current IUDs are with progestins that do sort of induce breast proliferation, so that might not be the optimal answer. I think beta-doxephene may be an option that could at least not worsen breast cancer risk, but we don't know that yet. And another thought from a breast expert is that if you need to do hormone therapy to manage symptoms at the time of menopause, there's no reason why after that you couldn't do a course of risk-reducing therapy with tamoxifen or raloxifene to reduce their breast cancer risk. So it's not that you do all of it at once, but that might be a sequence to help lower risk for women who have that concern or at increased risk to start with.
Andy, you mentioned that there was a relationship between symptoms and cardiovascular disease. Is it clear that the symptoms are causally related to cardiovascular disease?
No, it's not clear. It's being looked at. The SWAN study is the only one who's looked really carefully at the physiology underlying what's happening with hot flashes. And there's clearly the vascular changes that hot flashes seem to be a marker for, but we don't know much beyond that at this point.
One other question, and you concentrated on the perimenopause, but an incredibly common question is, how long should I continue my estrogen beyond the immediate perimenopausal period? How do you talk to people about that?
We don't have an exact answer for that, but because of SWAN, we know that we would expect on average 7 years longer for African American women. I didn't say it, but when SWAN looked at that study 13 years out, 25% of women were still having hot flashes, so they hadn't finished. And that fits with what we know that about 25% of women in their 60s and 10% of women in their 70s will continue to have vasomotor symptoms. So if other health conditions allow, then it may be reasonable to continue for a very long time in those women if they get significant benefit. We don't know exactly of a time frame for when we have to stop.
Thank you so much. We had a similar question online and also a second question. Can you comment at all on Alzheimer's or dementia risk in women and any connection?
I had this slide. I have a series of slides for the common questions. So we know much less about this than we wished we knew. We do know from randomized controlled trial that women who undergo bilateral oophorectomy have improved cognition if they're given estrogen therapy immediately compared to those who receive nothing. From the WHI, we know that giving oral CEE and MPA doubled the risk of cognitive decline, but we didn't see that with estradiol alone. And in the WHI, for women in the age group of 60 to 65, they didn't assess cognitive abilities during the trial, but they assessed it after the trial was over. And for those women, there was no difference in cognition between those who received placebo, estrogen alone, or the combination therapy. There have been a number of observational trials. They're in the newspaper every month or two, showing a benefit or worsening dementia. They always have relative risks. They're under 2, so they're within the range that we worry about bias in observational studies. Some studies suggest a timing effect, but we really don't know. And so at this point, I would say there's no role for giving MHT to prevent dementia, but probably not to worry about harm when giving it to younger women.
Fabulous. Thank you so much. I am noting we are right at the top of the hour of 9 o'clock. Dr. Clark, thank you so much. And what a tribute to Dr. Kammer.
Thank you very much.